Tonight, we're going to have Dr. Madeleine Duvic with the Department of Dermatology at MD Anderson Cancer Center, and also Dr. Richard Hoppe, who is a radiation oncologist at the Stanford Cancer Center. And Dr. Hoppe is live with us. Thanks for being here, Dr. Hoppe.
Sure. Pleasant to be here.
Yes, we are super excited to have you here. And tonight, folks, the way it's going to work is if you have a question, you can just go ahead and submit it into the Q&A box at the bottom of your screen. There's a little icon there that says Q&A. You can also submit it via chat. That will work as well. So the first question is, as it can take years to correctly diagnose cutaneous lymphoma with biopsies, are there any new ways to diagnose it sooner? And how does the patient cope until diagnosed? I don't know if either of you, Dr. Hoppe, start with that one.
Yeah, I'd say that, the definitive diagnosis still requires biopsy documentation for classical mycosis fungoides. There are some changes that can be apparent in the blood, but generally we wouldn't treat based on that alone.
Okay.
We might add that it's possible to sequence the T-cell receptor genes at different places, like in the blood and the skin, for instance. And if they're both positive with the same sequence, or they're clonal, and that helps you make the diagnosis earlier if you can do it. It's an expensive test. So.
Mm-hmm.
Yeah. And in terms of, what to do in the meantime, it's really, symptomatic care for treating pruritus or and so forth.
Okay.
I look at it early MFs like eczema. There's an inflammatory reaction there. It usually is sensitive to steroid therapy. And I have no problem at all treating what isn't MF yet by all the required criteria, but it looks like it's going to be MF pretty soon, if not someday. So why not treat it? Get it to go away.
Mm-hmm.
But the treatments, I agree with corticosteroids topically, certainly. I'm not sure more definitive treatment for MF would be appropriate. Madeleine, would you use anything more aggressive than?
I've used mid-potency steroids or Clobetasol, strong steroids if they're smaller lesions, and triamcinolone if you need to cover more. And I think that the combination of topical steroids and light, phototherapy, UVB, clears some people completely for years. So it's a benign treatment and works for a lot of patients.
Okay, thank you both. Let's see, the next one, is there a preferred steroid cream for treating LYP?
Clobetasol is a strong potency steroid, and it works pretty well for LYP.
Okay.
Yeah, I agree.
Okay. Is CTCL considered a skin cancer as opposed to a blood cancer?
Somewhat of a semantic issue.
Okay.
I usually tell my patients that it's primarily a skin disease, a lymphoma of the skin that can also overflow into the blood. That is, the classical MF. But then you have the Sezary variant, which really has major manifestations in the blood, in the peripheral blood, but has very specific skin involvement as well. I try to lean away from trying to designate it as a skin cancer or a blood cancer.
Mm-hmm. Do you have anything to add, Dr. Duvic?
Well, yeah, I agree. I wouldn't call it a skin cancer because it's not really due to the skin. It is due to a lymphocyte that gets in the skin, and that presence of that lymphocyte makes the skin change. It makes it scaly or itchy and redness. So it's actually both a blood disease that manifests in the skin, and I wouldn't call it skin cancer.
Okay. let's see. If someone is 1A, has MF, and under no treatment at this point, they are in remission, they had UVB treatment initially, what would be the recommended interval for cytology testing while in remission?
Wow. Why do you need it?
Yeah.
Yeah.
A clear patient's a clear patient. You just
Okay.
follow them.
Okay.
Yeah.
I wouldn't spend their money to do tests that aren't necessary.
Okay.
Yeah, and I'm not sure what the questioner means by cytology, whether that means biopsy of the skin, but generally, we rely on just that visual clinical observation. If there was something suspicious on the skin, would rebiopsy it. But if there's nothing suspicious, if the patient appears to be in a complete response, we would just follow that patient in clinic, ultimately just once a year for a skin exam.
Okay.
If you are having lesions, then I'm sorry. If you're having, I'm sorry. Let me think about what I'm going to say. Go ahead.
Take your time.
I've lost my train of thought. I'm sorry.
Okay, that's okay. We all do it. Let's see. Upon receiving radiation for MF, plaques, and tumors, is it possible for plaques or tumors to return in those specific areas, or is that unlikely?
Yeah, well, it's very much related to the dose that's given. Essentially, the higher the dose, the less likely that a plaque or tumor will recur in that site. Now, you don't want to use too high a dose because then you may have, some secondary skin toxicity, some telangiectasias, like superficial blood vessels that show up, or some thinning of the skin. So it's a clinical judgment on what dose to use. Lesions will go away even with very low doses of radiation, but with the very low doses, they may come back. So it's a clinical judgment that the radiation oncologist has to use.
Okay. Let's see. Just diagnosed with FMF. Is there different treatment for it? Bexarotene oral versus topical? Dr. Duvic, do you have any suggestions?
Folliculotropic MF, is
correct.
That what they mean by
That's
FMF?
correct. Yep.
Folliculotropic to me is the hardest to treat because the cells are down deeper and they're around the hair follicles. So I think you usually end up needing a combination of therapies, skin-directed, either steroids plus something oral, such bexarotene's a good choice, interferon's an okay choice, and sometimes it doesn't respond to those either. So we're trying other things like brentuximab vedotin if it's got a lot of CD30 expression. So I think it's the hardest kind to treat.
Okay.
Yeah, if the disease is localized, those are patients that we will often initially use radiation for, since the radiation is more penetrating than other topical therapies.
Okay.
It gets down to the depth of the hair follicles.
Okay. Let's see. Can you speak to treatments for B cell, CBCL, other than radiation or rituximab? What do you recommend for patients who were doing rituximab maintenance in light of COVID-19? Let me know if you need me to repeat any of that. So for CBCL, other
there
than
are different kinds of B cell lymphomas come in different varieties.
okay.
Are we talking just skin basal BCs? Skin BC is, if it's just a few lesions, radiation's great for that.
Okay.
And you can do intralesional steroids.
Okay.
Or intralesional rituximab. It's when you have a systemic B cell lymphoma that requires rituximab plus something else, maybe.
Okay.
If it depends on how extensive it is.
Okay. Dr. Hoppe, did you have anything to add to that one or no?
Yeah, well, I was, the question is a little unclear. It sounded like the person asked other than radiation or rituximab, but
Yeah.
radiation, certainly radiation, or even, if they're small lesions, you can excise them. But that's the conventional standard therapy for cutaneous, that is skin B-cell lymphoma, and those treatments are very effective.
Okay, great. Thank you. Let's see. I have MF and minimal blood involvement with about 1250 in the CD4 positive, CD26 negative flow cytometry and several biopsies with large cell transformation. I had a recent biopsy which reflected a CD30 component. Brentuximab was supposed to target CD30, but has done nothing for that biopsy site. Why? And that was long-winded for me, so let me know if you need me to repeat anything else. Dr. Duvic, do you have anything on this one?
I think I'd need to know more about the patient.
Okay.
That's a low blood involvement. I don't know why CD30 is not working. It sometimes does and sometimes doesn't.
Okay.
Yeah, the response rates aren't 100%. So,
Right.
you will see, at times lesions don't respond. It's no guarantee, even if the biopsy shows CD30 positive.
Okay. Sort of a general question. Could you discuss the different types of phototherapy?
Well,
Our dermatologist expert.
There's sunlight, which is a combination of UVB mostly and a little UVA. UVA goes deeper than UVB, so it's more likely to cause skin cancers later. UVB is a shorter wavelength, but it's pretty effective. If you need more deeper, there's something called PUVA, which is psoralen by mouth, which is a photosensitizing drug, plus UVA, and that's stronger than UVB. And sometimes we use it for extensive plaque disease. There's narrowband UVB, which is, I think, a smaller amount. I think it's 310. Is that Dr. Hoppe probably knows more about this than I do.
Did you have any follow-up on that, Dr. Hoppe? 310, she said?
No, I don't have any follow-up on that.
Okay. Let's see. Was there anything additional, Dr. Duvic?
No, I mean, just ask for the different kinds of phototherapy. There's also photopheresis, where you take a sensitizing chemical and put it in the bloodstream and then run the blood through a canister that has a light in it. So that's another type of radiation to the blood, of ECP or photopheresis.
Okay. Someone asked for CTCL. When do you watch and wait? Dr. Hoppe, any?
Yeah, well, I mean, certainly our philosophy has always been that if you treat the skin, the apparent skin lesions, that the likelihood of dissemination is less. That's sort of our philosophy. So I'm not sure we'd ever leave anything totally untreated. We would at least use topical corticosteroids for limited disease. But if the disease is asymptomatic, if you have a patch and it's asymptomatic, and the patient was reluctant to have treatment, well, could simply follow. It's when it presents as a very limited disease, it's usually very indolent as well. Uncommonly progresses to more advanced stage of disease on the skin. And, so that would be okay. I wouldn't advise it.
Okay. Dr. Duvic, do you agree with that?
I watch and wait a patient who's in complete remission and doesn't need treatment because they've been in remission for years or whatever. I don't usually watch and wait active lesions. I usually try to get them to go. But some people do. And if they're stable and the patient's not bothered by them, that's an okay thing to do.
Okay.
For selected patients.
Right. Okay. Let's see. If you are diagnosed at 2B, is it possible to be downgraded back to stage 1, or will I always be a stage 2 patient?
Well, staging's done at the time of diagnosis, and the stage you get then is your stage forever. However, it's certainly possible for someone who's 2B, which means tumors, to go back to 1A or B, which is flat lesions. So yes and no,
Okay.
or no and yes.
Yeah, it's somewhat of a semantic issue again. Technically, you would say, patient presented initially as stage 2B now has just minimal plaque disease or patch disease. It's somewhat semantic, but in lymphomas, always, as Dr. Duvic said, the stage you have initially that's designated as your stage forever.
Okay. When do you decide to use interferon treatment, and how long do you wait before changing to other treatments?
I like interferon a lot in younger people, especially if we have young adults who aren't responding just to topical steroids. A very low dose of interferon can cause complete remissions. I like it in combination with photopheresis a whole lot. It works better. Photopheresis works better when you combine it with either retinoids or interferon. What was the other question?
And how long do you wait before switching to another treatment?
Well, that depends on the severity of the disease and the symptoms of the patient, and if the patient's progressing on it, then you would stop it and go to something else. Or if the patient couldn't tolerate the side effects and a dose reduction didn't help that, and you would go to something else. But interferon is a treatment that can be given for years and with good results. It's very good in early Sezary as well.
Okay. If you are currently taking brentuximab, do you know if it is safe or effective to take the COVID vaccine?
Yes, take the vaccine.
Dr. Hoppe, do you agree?
Yeah. There's no evidence that brentuximab would, provide immunosuppression that you would not respond to the vaccine. The situation is different for rituximab. That starts with an R, which is a treatment for B-cell lymphomas. And there's some evidence of that you should wait, some say at least 3 months after the cessation of rituximab before being immunized.
Okay. Dermatology question here. I had great results with tanning 20 minutes each day, same time of the day, instead of PUVA or UVB. After radiation, is this still an option? And how long does the skin need to heal from the radiation? Dr. Duvic?
No, that's Dr. Hoppe's question.
Yeah, well, so, well, maybe for both of us, but I'm not sure what type of radiation we're referring to here. Is it total skin irradiation? If so, usually, the healing from total skin irradiation, occurs over a period of several weeks. But I'm not sure I would endorse the use of simple tanning as opposed to more controlled UV exposure. Madeleine, any thoughts about tanning?
Well, tanning 20 minutes a day each day is a lot of tanning. That would maybe predispose to later skin cancer. So you want to take as little as possible to do the job. But most people, I recommend 3 times a week, not every day. And certainly not, and you don't want to burn. So that burning is a bad thing. Mm-hmm. So I don't know if this tanning means she's out in a tanning bed or lying out on the beach, or I don't know how much dose she's getting, or she or he are getting. Okay.
Let's see. So it'd probably fluctuate if it was natural sunlight or a tanning bed then, correct?
Yes.
Okay. Let's see. Someone asked, I'm responding well to triamcinolone and clobetasol and phototherapy for folliculotropic MF. My PET and CT flow cytology were clear. When do you go to further treatment?
When it stops working?
Okay.
Yeah, right.
Okay. Let's see. Can you talk about whether there is a problem with using dry eye treatments such as Restatis eye drops, which are supposed to work with T cells in the eye in order to be effective?
Well, Restatis, I think, has immunosuppressive component to it, isn't it? What's the name of that? Doesn't it have like cyclosporin? Isn't that part of Restasis?
Dr.
So-
Hoppe, do you know?
Yeah, I think you're right. Yeah.
Immunosuppressive. It kills good T cells. So I don't know if there's any data on using it in MF patients.
Okay.
It could be okay. It might not be. I don't have any knowledge of that being looked at.
Okay.
Yeah, I haven't encountered any patients who are using Restasis that have been treated for MF.
Let's see. If there is no presence of blood involvement, only skin involvement with regards to MF, is there a risk of blood involvement in the future?
Yes, there is. Yeah,
Yeah.
it can be a systemic disease. I mean, and it manifests itself mainly in the skin, but you certainly can develop blood involvement over time, more evident blood involvement over time.
Dr. Duvic, I heard you say yes as well. You agree with that?
I do. But most of the people with MF, plain MF, the classic kind, don't progress to blood involvement. They usually progress in skin. And so the people who get blood involvement often get itching and redness and look like red people, Sezary syndrome. They're the ones who've gotten blood involvement. So anything can happen.
Okay. Have you seen CTCL lead to macular amyloidosis from the profound itching? Are they treated the same and by the same dermatologist? Thank you.
Macular amyloidosis looks like hyperpigmentation or darkening of the skin from chronic itching. So it can be a secondary condition of any chronically scratched skin. It's not serious. Macular amyloid is more of a cosmetic problem.
Okay. And they also said, are they treated the same and by the same doctor? So I would assume yes.
Pretty much,
Okay.
yeah.
Okay. Let's see. Are immune suppressed patients receiving protection from any or all of the COVID vaccines available?
That's a great question.
It's hard to know probably at this point.
Yeah, there's a lot we don't know about the disease and the vaccines. So I'm not sure we can answer that.
Okay, things everybody wants to know at this point. Let's see. With a secondary disease caused by 2 years of scratching before getting to see a dermatologist, confirmed by biopsy, why does the dermatologist settle for that and stop doing biopsies even though they diagnosed MF on inspection of your rash?
Why do they keep doing more biopsies?
It
After
looks
they
like
might want to look for large cell transformation if you've gone and gotten a tumor,
okay.
or if you're getting different kinds of lesions like follicular papules, or if they want to do some testing of immunomarkers like CD30 or others, they might take a biopsy for that. But after you make the diagnosis, you don't really need to keep taking biopsies unless there's a change of some sort that needs investigating,
Okay.
in my opinion.
Okay. Anything to add, Dr. Hoppe?
Yeah, no, I would agree that if there's a change in the behavior of the disease, it looks like it's becoming more aggressive. You may suspect large cell transformation, for example, but otherwise, no, if the lesions are confusing to the dermatologist and it's not clear or obvious that it's MF and there might be some other overlying disease, sure, biopsy. But if everything is consistent with MF and the aggressiveness of the disease hasn't changed, there isn't much indication for biopsy.
Okay, thank you. Let's see. Having MF stage 1A locally in only one area after 2 attempts of excision, which have not stopped the plaque coming back, we have decided to do radiation. Now it seems a new plaque appears again in the same area just 6 months after radiation. Not sure what to do on how to confirm if it is MF again, and if it is, what would be the treatment options?
Well, the main way to know if it's MF is to biopsy. But I mean, this scenario sounds unusual. First that it was the attempt to treat was with excision, which is not usually a primary treatment that we use. And then, of course, it's going to depend, as I implied earlier, depend on the dose of radiation with respect to the likelihood of control. Usually, if we have just this unilesional MF, just one patch, we'll use a somewhat higher dose than if we're palliating other areas for someone with more advanced disease in order to ensure a greater likelihood of permanent local control. It would be unusual if there was a definitive dose of radiation for it to come back in that site if it was only a patch to begin with.
Mhm.
I don't think there's any place for excision in treating MF lesions. It's a systemic disease that may start in the blood, and I just don't think that's going to cure anybody.
Mhm.
But I would always think about re-radiating an area that had come back after a long period of time.
Mhm.
That would be reasonable. But you could switch to nitrogen mustard or some other retinoid topicals or other things.
Okay. I have had about 5 brentuximab treatments with some reduction of superficial tumors and plaques. After the 5th brentuximab treatment, I have developed significant side effects that are pervasive with an overall loss of well-being. Is it time for romidepsin? And then they added, I have MF, large cell transformation with minimal blood involvement. I am 72 years old. I can repeat any of that if needed too.
No, I mean, I'm thinking about it.
Okay.
You say you're having problems with brentuximab vedotin. The one that's a drug stopper for me is peripheral neuropathy, because if that goes on, you can lose the feeling in your feet, and it's unpleasant. So if that happens, then you have to cut it or stop it or take a break and let it come back. I wouldn't know what to suggest, what kind of treatment to suggest without seeing you and knowing you better. I'm sorry.
Okay.
Yeah. I agree. And, there are some scenarios like this where, since I'm a radiation oncologist, I have to say, radiation might be appropriate. But, without seeing you and, knowing more extensively what prior treatments have been used, it's impossible to make a recommendation.
Let's see. Which doctors inject rituximab into lesions? Is it a dermatologist? If a patient has multiple lesions recurrent, what is the recommended treatment?
Did you say brentuximab or rituximab?
Rituximab.
With an R.
Yes.
And then what else did they ask? I'm sorry.
Which doctors inject rituximab into lesions?
Well, dermatologists can inject it into B-cell lesions. I don't think that oncologists do much of that. They think more in terms of IV drug administration.
Okay.
But intralesional rituximab is helpful in treating B-cell lesions that don't respond to steroid injections.
Do you agree with that, Dr. Hoppe, or have anything to add?
Well, I would say, Yeah, if rituximab were to be injected directly into lesions, would be the dermatologist, but radiation therapy should be used as a primary modality for simple cutaneous B-cell lesions because the response rates are very high, and and as well, lesions can be excised. Cutaneous B-cell lymphoma, can be treated surgically if the lesions are small and they're not going to leave any cosmetic deformity.
Mhm. Okay.
Yeah, I agree with that too. I think radiation's incredibly favorable and doesn't need very much of it for B cells. And
Okay.
I think that lesions can be injected, B cell lesions can, because you can get around them and have a border, whereas MF is more flat and harder to get a border for
Okay.
excision.
Because FMF is more difficult to treat, do I need an expert in FMF, or is a doctor with knowledge of mycosis fungoides sufficient?
I would say that you should always be treated by someone who is expert in this disease because it's a rare disease and there are many, subtleties of the disease, and whether it's follicular MF or conventional MF, I would say you should see somebody who is expert in the disease.
By this disease, you mean MF, not follicular MF, right?
It sounds like they're asking if they have FMF, do they need to be treated by a doctor with more knowledge of FMF rather than just MF?
I think if someone is an expert in MF, they would know what to do with follicular MF.
Okay. Okay. Let's see. Since we do not know the efficacy of vaccines for lymphoma patients, what are you recommending to your patients who have been vaccinated? I assume they mean with the COVID vaccine. And I assume that they're asking how careful they need to be, or if you have specific recommendations for folks who have had their vaccine.
Yeah, they should still follow the current recommendations of social distancing and using masks. You can still get infected, if you've been vaccinated. You may not get ill, but you're still capable of transmitting the disease.
Dr.
And
Duvic,
so for the time being, at least right now, we're recommending that our vaccinated patients continue with the precautions that have been recommended by the CDC.
anything to add to that one, Dr. Duvic? Sorry, it's kind of hard with the phone.
Yeah. Well, I mean, I agree with what Richard said.
Okay. Let's see. Is there a difference between Clobetasol and Halobetasol for treating skin lesions from LYP? Dr. Duvic?
There hasn't been a test to compare them, but they're similar in strength and should work the same.
Okay. Let's see. Thoughts on, I'm going to slaughter this name, I'm sorry, Dupixent for patients with MF and atopic dermatitis?
There's some literature that's coming around that some patients will develop problems when they take that, like Dupixent given to someone. It's not clear whether the patient already had MF but was called eczema, got Dupixent, and then got worse lymphoma that was diagnosable, or whether there's really association. Whether it's safe, but it is effective in some patients who are more atopic, but then if their lymphoma progresses, you don't know whether it's causal or not.
Okay.
So I would not recommend Dupixent for CTCL patients at this time. In fact, it's contraindicated probably.
Okay. Is it recommended to do a biopsy in an area where the plaque reappears 6 months after a high dose electron beam radiation to confirm that it is actually MF and nothing else, although it does look the same as before?
Well, I would say it depends on what you're planning to do. if you're just going to use some topical therapy on this lesion, I'm not sure you need to prove that it's MF, but perhaps if you were planning on some more intensive treatment, you might want to be certain.
Anything to add, Dr. Duvic?
You might want to see if it's CD30 positive, for example. But I don't think you have to biopsy it if it doesn't change your plan of action.
Mm-hmm. Okay. Thoughts on protopic for facial plaques or patches? Dr. Duvic, any on this one?
Do you want me to answer? Or
Sure.
protopic is an it gets rid of T cells. It's been used on the face with safe findings. I'm not aware that there's literature saying that it's bad to use protopic. Protopic's probably safer than Elidel, which is the other steroid-saving drug in this class. Okay. So I think it's one option for the face.
Okay. Dr. Hoppe, anything to add on that one?
No.
Okay. Let's see. Is a partial response or stable disease response to a specific medicine a good outcome, or is it always a complete response to treatment the preferred outcome? I was always told that a complete response to treatment may not always be achievable and that there is no complete cure.
That's multiple questions there. Yes, it's likely there's no complete cure, although, we all have examples of patients who have had therapies and have had a long period of time without any disease activity, who we, feel may be cured, but there's no reliable curative therapy. Even the stem cell transplants cure only a portion of patients. So there's nothing that's reliably curable. Of course, a complete response is always preferred to less than a complete response. But, sometimes even partial responses can be very important for a patient. They can be significant. They can have relief of symptoms or improvements in cosmetic issues. So yes, complete response is best, but if you can only get a partial response, that's fine. Sometimes stable disease may be adequate, but usually you'd want to try a different therapy if all you've achieved is a stable disease.
I agree with everything you said. I think that MF patients are heterogeneous, meaning that each one's different. And there are cures, but some of it's due to luck. It is possible to cure it, but it's not the expected outcome. Most people just get better and hold it, and that's good if it controls the symptoms.
Okay, thank you. Let's see. Are there complications from using clobetasol for a long period of time? The instructions say to apply it to the lesions, but I have a lot of lesions all over my trunk and legs and arms. So is it dangerous to rub the ointment all over?
Well, you might absorb some of it, and it can cause problems with your adrenal gland. But clobetasol is a spot treatment for limited lesions. It's not an all-over therapy. And if you use too much of it, you can get thinning of the skin where you use it. And as I said, if you use too much of it, you can get adrenal insufficiency.
Mm-hmm. So should they try to just keep it isolated to the spots as best they can?
Or yes, but they probably need a different therapy.
Okay.
Generally for more generous application of corticosteroids, we use something like triamcinolone.
Mm-hmm.
That's
okay.
true.
Thoughts on doxycycline for CBCL?
For what?
CBCL, B cell.
Oh, okay, doxycycline.
Yeah.
I usually give it if the person has a new diagnosis of cutaneous B-cell lymphoma. I usually get a Borrelia titer. Certainly, if that's positive, then you would treat with doxycycline. And there are cases that improve or go away with doxycycline. But I think it's a minority of patients, especially in this country.
Yeah, I agree.
Okay. I had 2 biopsies which confirm MF with, let's see, with large cell transformation and CD30 cells present. The tumor's biopsies went away and never came back. So why not biopsy all superficial CD30 MF large cell transformation tumors with the expectation that the tumor will go away and not come back?
I don't understand the question. Sorry.
Okay.
Yeah, I'd say that every once in a while, either with the cutaneous B cell lymphomas or with MF, after you do a biopsy, it incites some, a local inflammatory reaction that may lead to regression of disease. But I don't think we can rely on that to be a general treatment.
Okay. For those who have had the vaccine and are not sure if it is effective due to lymphoma and prior treatments with rituximab, can an antibody test resolve these uncertainties? Is there any particular test which is more reliable?
Well,
Sorry, Dr. Duvic, go ahead.
Well, the antibody, you can measure the antibodies in the blood, and if they're there and high, then you would expect there is some immunity to the virus.
Dr. Hoppe, anything to?
Yeah, so the problem is that if you do the antibody test, it will not always be positive if you've been vaccinated, even if you have adequate protection. So certainly if you've had an actual COVID infection, your antibody test should be positive. But it's not always if you've been vaccinated, just because of the antibodies that develop in response to the vaccine versus the actual infection.
Okay. Someone just said the possibility of a cure may have been suggested. Can that be objectively ascertained via testing? So I assume they mean if they're a candidate for stem cell or.
Well,
sorry, go ahead, Dr. Hoppe.
You have to evaluate to say something is completely cured. It has to have every skin node and blood all have to be negative for the disease. I mean, I don't understand. What was the rest of the question about?
They just said, can that be objectively ascertained via testing? I wonder if they mean, is there a way to know if they'd be a good candidate for stem cell? That would maybe be how I read that.
Well, you have to be in complete remission to go to stem cell. Is that, maybe that's what they're talking about.
Okay.
Yeah, there's no simple test to know that there's, that you're so-called cured, or no evidence of disease. As Dr. Duvic said, it's a combination of appropriate evaluations of the skin, the lymph nodes, the blood, and the viscera. And depending on where the disease was to begin with, you might focus your evaluations on those sites. But there isn't one simple test.
Okay. Let's see. I have stage 4 Sezary since November 2013. I have had multiple treatments over the years. Since 2018, I have taken Moga. My blood is good, but my skin is not. I had total skin radiation this past fall with great results. However, they were short-lived. Have you added any drugs along with Moga to help with the skin conditions? And what do you recommend for dealing with tumors affecting the skin? I have dry, open sores and itch. Let me know if you need me to repeat any of that.
Well, it's difficult to know what to do when you haven't seen a patient and know more about the records and the doses.
Of course.
I think that electron beam total skin is extremely helpful in patients that have a lot of tumors. But sometimes when you treat tumors, you get holes. Sometimes those holes are infected, and patient can respond to a course of antibiotics, and some wound care can help people with open sores like you're describing.
Okay.
That's the only comment I made.
Okay. Anything to add, Dr. Hoppe?
Yeah, I agree that it's unclear, without seeing the patient. I'm not sure, are the ulcerations a result of treating tumors that have gone away, or are these ulcerations reflective of active mycosis fungoides? Without need much more information.
Yeah, this one was unfortunately submitted ahead of time, so we can't clarify. But is hypopigmented MF considered a variant subtype of its own, or is it just considered an atypical presentation of classical MF?
Well, you can argue about that for a long time. Some people think it's its own disease, and some people think it's a variant. I think it's a variant because there's so many different kinds of variants. This one is lighter skin, and actually, interestingly, this is more common in children, and it has a very good prognosis. It doesn't usually progress. I've never seen a case progressing, and it responds to light. And it's interesting that the children who get this are vitamin D deficiency. They're very low in vitamin D, and that may help to treat them, replacing it.
After completing phototherapy with clinical resolution of the lesions, is there good evidence behind doing maintenance phototherapy after for MF patients?
You want to take that one?
Dr. Hoppe, do you want to take this one?
Well, yeah, since, I'm not a deliverer of phototherapy, so, but I would suspect there isn't any high level evidence, but I would defer to Madeleine on this.
Okay.
I think what I do is I start people off on 3 times a week UVB, and then if they clear, I don't stop it. I taper it down slowly. So maybe we would go to 2 times a week, and then 1 time a week, and then maybe every 2 weeks. And that maintenance can help to prolong a remission.
Okay. Let's see. And we are actually on our last question here. What treatments, we got another one. What treatments or drugs other than photopheresis targets involvement in the blood?
Well, interferon, mogalizumab, pretty much any systemic drug would have some effect on blood.
Yeah. You also, romidepsin, the HDAC inhibitors.
Photopheresis, of course.
Okay. I have nail involvement with FMF. Should commercial manicures or pedicures be avoided? And then they said, what treatment is available? I assume for the nails.
Well, the first thing to do is make sure that the nails aren't infected with fungus.
Okay.
Because that can look like MF, and you can cure that with pills. I don't have experience with much in the way of nail MF, so radiation might work.
Okay.
Yeah, I mean, it sounds very odd, though. I also, have never seen any kind of documented case of even, ordinary MF involving the fingernails or toenails.
Okay. Let's see. And this will be our last question tonight. I am a 71-year-old male diagnosed in February 2020 with CTCL CD30 positive, now identified as PCALCL. I have multiple lesions on my face and scalp. I have tried Clobex spray for the scalp with marginal success. Desinide for the facial lesions have been unsuccessful, and I have recently had 3 doses of radiation for the facial lesions on the lower half of my face. And they added each of 500 C gray Is this considered a strong dosage?
Well, so if I interpret that correctly,
Mhm.
um, that the same area was treated with 3 doses of
Yes,
500 centigrade, as
correct.
opposed to 3 different areas, each receiving
Yes.
500 centigrade. Uh, so, well, that total dose then of 1500 centigrade for anaplastic large cell lymphoma is an acceptable dose. The size of those of each individual treatment is rather large, but again, this is sort of clinical decisions on the part of the radiation oncologist on what appropriate uh, dose per treatment to use, depending on the body surface that's being treated, and uh, uh, but the total dose in this case is one that's reasonable for anaplastic large cell lymphoma.
Okay. Anything to add,
And
Dr. Duvic?
well, this is a patient who might benefit from brentuximab vedotin if they're CD30 positive.
Okay.
Even patients who aren't CD30 positive who have tumors respond somewhat. So if the radiation doesn't cure the lesions and they are coming back and you can't give more radiation, that might be a good thing to try.
Yeah, and even, it sounds like he has a lot of lesions, not just the area that was irradiated.
Mm-hmm.
And it's sometimes very challenging to irradiate large portions of the scalp or face. And brentuximab, certainly would, I agree with Madeleine, would be considered a good option here.
Okay. Great. Well, we don't have any more questions open right now, so we'll go ahead and wrap up. Thank you both to Dr. Hoppe and Dr. Duvic for being here with us tonight. We really appreciate it.
Our
You're
pleasure.
quite welcome.
And we have
Happy
a
to be
couple
here.
people typing in here. Thank you to you both. So we are so appreciative of your time, and a heartfelt thank you to our corporate partners and individual donors as well. Thanks for making these programs possible. And just so everybody knows, on Friday, we will be having a COVID-19 vaccine specific related webinar. So if you're able to join us for that, it's at 6 o'clock Eastern time. We hope to see you there. And with that, we will wrap up here. We hope you enjoy the rest of your evening or afternoon, depending on where you are. And thank you again, Dr. Hoppe and Dr. Duvic, and have a great night, everybody.
Okay.
Thank you.
Bye-bye now.
Welcome.